Hello, everyone, and welcome. On behalf of the GLODERM Training Committee, it is a privilege to open this global webinar series dedicated to Hidradenitis Suppurativa awareness. We are grateful to each of you who are joining us from around the world to deepen our shared understanding of this profoundly impactful and often misunderstood disease. My name is Alexa Reese, and I will be your webinar host for this series. Before we begin, I'd like to briefly introduce GLODERM and the GLODERM Training Committee, the group organizing this series. The International Alliance for Global Health Dermatology, or GLODERM, is an official program of IFD under the International League of Dermatological Societies, or ILDS. GLODERM's mission is to improve skin health for everyone everywhere. And the GLODERM Training Committee is run by trainees as part of GLODERM. The committee's mission is to promote knowledge equity by enhancing access to dermatology education worldwide. Some of the key initiatives include educational webinars that you'll be seeing over the next couple of days, networking and collaboration to connect trainees worldwide, and a podcast series addressing challenges in global health dermatology. This awareness series was developed to complement HS Awareness Week, which is the first week in June every year, an annual campaign dedicated to increasing public understanding of hidradenitis suppurativa, reducing stigma, promoting earlier diagnosis, and supporting people living with the condition. This matters because HS remains a condition marked by delayed diagnosis, under-recognition, and significant stigma. And our educational series supports this ongoing education on evolving therapies and multidisciplinary management. So we really encourage you to get involved as we think about HS awareness by participating in educational webinars like you are today, sharing your clinical insights and resources with colleagues and patients, engaging with patient advocacy groups and research initiatives, and promoting awareness through your clinics and social platforms. Over the course of this series, we'll explore HS from multiple angles, including the epidemiology, impact on quality of life, comorbidities, and the full range of treatment approaches. Our goal is to equip clinicians with practical, evidence-based knowledge while also fostering empathy and reducing stigma worldwide. This series will be broken down into 3 parts, with the first part working to understand HS, including the global landscape and early diagnosis. Part 2 of this series will cover living with HS, access to care and quality of life. And Part 3 will include a live speaker panel discussion for all of your questions to be answered. Regarding general webinar etiquette, your audio will be muted and your camera will be turned off for the live Q&A. If you have any questions or comments, please submit via the YouTube chat box. Our speakers will answer these questions during the live speaker panel, and we'll be sharing information about the GLODERM Trainee Committee and how to get involved in the YouTube chat box. So make sure to take a look at that during these series. To open this series, we are honored to welcome our first speaker, Professor Benhadou, to discuss the global landscape of hidradenitis suppurativa, including clinical presentation, epidemiology, and worldwide impact. Professor Benhadou is Director of the Inflammatory Skin Disease and Clinical Research Unit in Brussels, Belgium. Her clinical and research activities focus on inflammatory skin diseases, with particular expertise in hidradenitis suppurativa, psoriasis, and atopic dermatitis. She is actively involved in clinical research and international collaborations dedicated to improving the understanding and management of chronic inflammatory dermatoses. We are so excited to be joined by Dr. Benhadou.
So good morning, everyone. It's a great honor to be here today on behalf of the Hôpitaux Universitaires de Bruxelles. And I would like to thank the organizers for this opportunity. Over the next 20 minutes, my colleagues, Dr. Elaïsouk Fadoua and I, will take you through the global landscape of hidradenitis suppurativa, its epidemiology, its clinical features, and perhaps more importantly, the enormous human and economic burden that this disease places on patients and on our healthcare systems worldwide. HS is not a new disease, but in many ways it is still a new field. And what I hope to convey today is that we are at an inflection point, a moment where the data demands that we change the way we think about, diagnose, and manage this condition. So let's start with the presentation. So the first question we need to ask is a deceptively simple one. How common is HS? And the honest answer is we don't fully know. The prevalence estimates reported in the literature vary enormously, and as you can see on this slide, the methodology used to measure prevalence drives the result more than geography does. Studies based on healthcare database records and diagnostic codes, the most conservative approach, report figures as low as 0.05 to 0.30%. Move to symptom-based questionnaire and you climb to 0.6 to 1%. Add a physical examination and some studies report prevalence as high as 2 to 4%. The best current estimates from a systematic review and meta-analysis by Ilfrey and colleagues places overall prevalence at around 0.4%. That translates to tens of millions of people worldwide. But the key message here is not a single number. It is the fact that methodology determines what we see. If we rely exclusively on administrative codes, we will always undercount HS, because HS, as we will discuss later, is a disease that hides. And this brings us directly to the problem of underdiagnosis, which I would argue the single greatest obstacle we face in HS today. The average diagnostic delay for HS is 7 to 10 years. This is not a statistic from the 90s. It was confirmed as a global problem by Saunter and colleagues in 2015, and the situation has improved only marginally since. What drives this delay? And three converging factors. First, a lack of awareness among non-dermatology healthcare professionals. General practitioners, emergency physicians, gynecologists, and surgeons, who are almost always the first point of contact for this patient, frequently do not recognize HS. Second, frequent misdiagnosis in the early stages. Isolated nodules are treated as simple furuncles. Abscesses are incised and drained without further evaluation, and patients receive repeated courses of antibiotics for what is assumed to be a local infection. And third, delayed specialist referral, even when the clinic picture should prompt it. The consequences of this delay are severe: disease progression, structural skin damage, scarring, and years of inadequate treatment. The burden accumulates in ways that become very difficult to reverse. So how do we fix the measurement problem? The Global Hidradenitis Suppurativa Atlas, also named GISA, represents one of the most important methodological advances in our field in recent years. Published by the team of Professor Jemek in 2024, it proposes a standardized three-step approach combining a validated screening questionnaire, physical examination, and structured disease assessment. What makes GISA transformative is not any single dataset. It is the fact that it allows direct international comparisons for the first time. When every center uses the same methodology, we can finally build a true global picture of HS burden. This is the kind of infrastructure that HS has been missing, and it will be essential for advocacy, for resource allocation, and for the clinical trials of the future. Let us now turn to the clinical feature and presentation of HS, because you cannot diagnose what you cannot recognize. The diagnosis of HS rests on three clinical essential criteria as defined by the European guidelines. First, typical lesions, deep-seated painful nodules, abscesses, and sinus tract. The word deep-seated is important. These are not superficial lesions. They arise in the dermis and subcutaneous tissue, which is why they are so painful and why simple incision and drainage so consistently fails. Second, typical topography. Intertriginous area, primarily the axillae, the perineum, the inframammary fold, and the inguinal region. The distribution is not random. It reflects the anatomical distribution of apocrine glands and the role of friction and occlusion in disease pathogenesis. And third, the chronicity and recurrence. By definition, at least 2 episodes within the last 6 months. HS is not an isolated event. It's a chronic, relapsing, inflammatory disease. All 3 criteria must be present. This is what separates HS from a simple skin infection. So once we have established the diagnosis, staging is our next critical step. The early classification remains the most widely used framework in clinical practice, and it defines 3 stages of increasing severity. Stage 1 is characterized by single or multiple abscesses without sinus tract formation and without scarring. These are patients who are suffering but whose disease has not yet caused irreversible structural damages. Stage 2 introduces sinus tract formation and early scarring occurring as a single or multiple lesions that are widely separated. This is the stage at which systematic intervention becomes clearly necessary. And finally, stage 3 represents diffuse or near-diffuse involvement, multiple interconnected sinus tract, abscesses across the entire affected region, and extensive fibrotic scarring. At this stage, surgical options become complex and medical treatment alone is rarely sufficient. The clinical implication is direct. Stage guides therapy. Early 1 patient may respond to topical and oral treatments. Early 2 and 3 patients require systemic biologics, and many will ultimately need surgery. So beyond early staging, we now recognize that HS encompasses distinct clinical phenotypes based on the elementary lesion pattern. The work of Lara-Corrales and colleagues published in the GLODERM in 2020 identified phenotypic subtypes including frictional, furunculoid, scarring folliculitis, conglobat, and syndromic variants through prospective evaluation. Why does phenotyping matter? Because a patient with predominantly nodular frictional disease has a fundamentally different therapeutic trajectory than one with a conglobat phenotype or syndromic presentation associated with inflammatory arthritis or metabolic syndrome. Phenotyping also has prognosis implication. It helps us anticipate which patients are at the highest risk of rapid progression and which patients require a multidisciplinary evaluation from the outset. The field is moving toward phenotype-guided treatment algorithms, and the more precisely we characterize our patient at baseline, the better our therapeutic decision will be. So still within clinical presentation, I want to highlight a rapidly evolving area, the genetic architecture of HS. Based on the work of Petukova and colleagues published in 2025, genetic study of monogenic HS suggests 2 clinically distinct subtypes, each driven by a different pathway with a different therapeutic implication. The first involves loss of function variants in gamma secretase genes, nicastrine, PSNN, and PSN1, leading to attenuated gamma secretase and PE3K signaling. This patient presents with follicular disorders and comedons and may respond to mTOR and PAKT inhibition. The second involves missense mutation in inflammasome genes, PSTP, P1, MEFV, and NLRP3, driving activated inflammasome signaling. Clinically, this patient shows systemic feature features: inflammatory arthritis, pyoderma gangrenosum, and mucocutaneous manifestation. The therapeutic target here is IL-1 inhibition. And the practical message is this: when you encounter an HS patient with atypical systemic features, think genetics, think inflammasome, and consider IL-1 blockade. This is the foundation of precision medicine in HS. So we have now established what HS looks like and how common it is, but understanding the true impact of this disease requires us to go beyond the clinic. The second part of this presentation addresses a question that is often overlooked in dermatology. What does HS cost? Not just to the healthcare system, but the patient's livelihood, mental health, and place in society. The answer is deeply concerning. So HS predominantly affects young adults, people in their 20s, 30s, and 40s. This is not coincidental. It means that the disease strikes at precisely the moment in life when professional identity is being built, when careers are accelerating, when the economic stacks are highest, and data are unambiguous. Over 50% of HS patients report that their career progression has been directly hindered by their disease. This manifests in two distinct patterns: absenteeism, missed work days during flares, surgical recovery, or frequently outpatient visits, and presenteeism, showing up to work while in pain, unable to concentrate, unable to perform, and the latter is harder to measure but arguably more pervasive. The cumulative effect is slower income growth, reduced professional advancement, and, as we will see on the next slide, a dramatically elevated risk of unemployment. So the unemployment data are striking. Across multiple cohorts, HS patients face an unemployment rate more than double that of the general population. This is not explained by age or educational level. It is driven by the disease itself. Even more concerning is the longitudinal data. Newly diagnosed HS patients carry an adjusted hazard ratio of 1.65 for permanent workforce exit. That means a 65% higher risk of leaving the labor market entirely, permanently, compared to matched control without HS. This is a cascading consequences. Long-term unemployment means loss of income, loss of health insurance in many systems, reduced access to the very therapies that could control the disease, and a vicious cycle of worsening disease and worsening socioeconomic status. HS does not just damage the skin, it dismantles professional lives. So the economic burden extends far beyond lost productivity. At the individual level, HS patients incur approximately $6,783 in annual excess healthcare expenditure compared to age-matched controls without HS. This figure reflects the cumulative cost of frequent specialist visits, repeated procedure, hospitalization, wound care, and increasingly expensive biological therapies. At the system level, the global HS therapeutic market was valued at around $1.2 billion in 2024 and is projected to reach 1.87 billion by 2033, driven by the expansion of the biologic pipeline and improving diagnosis rates. That projection is both a sign of progress, more patients getting treated, and an indicator of how vast the unmet need remains. A growing market for HS therapies means, above all, that we are still a long way from solving this disease. So one of the most striking patterns of healthcare utilization in HS is what has been described as ED cycling, the repeated use of emergency department as a primary point of care during flares. This happens for a predictable reason. Patients in acute pain who cannot access timely outpatient dermatology care have no other option. They go to the emergency department seeking pain management and incision and drainage procedures. The problem is that incision and drainage, while providing temporary relief, does not address the underlying inflammatory process. It treats the abscess, not the disease, and so the cycle continues. The consequences are measurable. Approximately 10% of HS-related ED visits now result in full inpatient hospitalization. And since the 90s, HS-related hospitalization rates have increased by 60%, reflecting both growing disease severity and persistent gaps in outpatient care access. This is systemic failure, and it is a very expensive one. So, what about the surgical burden? Surgery remains an essential component of HS management, particularly for patients with established sinus tracts and fibrotic tissue that will not respond to medical therapy. But we must be honest about the limitation of what surgery can achieve. Nearly half of surgical interventions for HS fail to achieve long-term remission. Recurrence after surgery is common, and each recurrence typically necessitates a more complex procedure than the last: wider excision, more extensive reconstruction, and longer wound care. The economic consequences are substantial: complex wide excision surgery and prolonged post-operative wound care generate significant direct costs, and repeated surgical episodes accumulate into a major burden for both patients and also healthcare systems. The strategic lesson here is integration. Surgery alone is not enough. Medical therapy alone is not enough. The best outcomes, as emerging evidence increasingly confirms, are achieved when dermatologists and surgeons work together using medical treatment to control systemic inflammation, while surgical intervention addresses structural disease. So HS does not affect all patients equally, and access to care is far from equitable. On the dimension of race and ethnicity, we know that diagnosis delays are significantly greater in racial and ethnic minority groups. Unfortunately, these disparities are driven by a combination of systemic biases in clinical recognition. HS can present differently across skin phototypes, and clinicians trained primarily on images of lighter skin may miss or misinterpret early lesion and by structural barriers to specialist access. On the dimension of insurance status, the data are clear. Patients with limited or no insurance coverage face severe barriers to biological therapies and specialized dermatological care. In systems where access to biologics depends on prior authorization, step therapy requirements, or out-of-pocket costs, many patients who would benefit from advanced treatment simply cannot access it. This is a health equity issue, not just a clinical one. Any serious effort to improve HS outcomes must grapple with these structural inequalities. So the psychological burden of HS is profound and it is increasingly recognized as a core comorbidity, not a secondary concern. Depression and anxiety are significantly more prevalent in HS patients than in the general population, and then in patients with most other chronic dermatological conditions. The reasons are not difficult to understand: chronic uncontrolled pain, repeated hospitalization, progressive disfigurement, professional and social losses. But HS also carries an elevated risk of suicidal ideation driven by the combination of chronic pain, social isolation, and the sense of helplessness that comes with a disease that feels uncontrollable. This is not a rare complication. It requires active systemic screening. And the concept of psychodermatology integration, embedding mental health professionals within dermatology care pathways, is increasingly recognized as essential for total patient care in HS. Yet, despite the growing evidence base, dedicated mental health support remains absent from the vast majority of HS care pathways worldwide. This is a critical and correctable gap. So closely linked to mental health burden is the issue of stigma, and the data are sobering. 74% of HS patients report experiencing stigma during their healthcare journey, not from a stranger on the street, but in clinical encounters from healthcare professionals in the places where they should feel safest. The intimate anatomical location of HS lesion, the groin, the perineum, the axilla, carries enormous cultural weight. Many patients describe profound shame around their disease. They delay seeking care not because they cannot access it, but because they are too ashamed to show their skin to a doctor. Cultural taboos surrounding these body areas can cause patients to postpone presentation for years, arriving finally with advanced irreversible disease that could have been managed effectively at an earlier stage. Addressing stigma is not a soft issue, it's a clinical imperative. Every encounter with an HS patient is an opportunity to either reinforce or dismantle that shame. How we speak about this disease, the language we use, the normalization we offer matters as much as the prescription we write. So everything we have discussed today converges on a single conclusion. HS cannot be managed by one specialty alone. The model of the dermatology treating the skin while everything else goes unaddressed, the pain, the unemployment, the depression, the surgical recurrences, the stigma is not sufficient. It never was, and the evidence we now have makes this undeniable. Redefining HS management as a multidisciplinary emergency requires three pillars working in integration. Dermatology, providing early, accurate diagnosis and aggressive biological therapy to control systemic inflammation before irreversible structural damage occurs. Specialized surgery, not as last resort, but as a strategic partner to medical treatment, addressing chronic tunnels and fibrotic tissue while medical therapy controls the inflammatory background. And mental health, with routine screening integrated into every follow-up, and access to psychological support for patients who need it. As one recent publication framed it clearly, transitioning from a skin-focused to a total patient care model is no longer aspirational. It is essential to prevent what can only be described as the socio-economic collapse of our patients. So to close the presentation, let me give you 4 messages. First, HS is vastly underdiagnosed. With an average diagnostic delay of 7 to 10 years, we are failing our patient at the very early first step of the disease. And every non-dermatologist should be thinking of HS when they see recurrent painful and deep-seated lesion in intertriginous areas. Second, clinical phenotyping guides management. Early staging and phenotype-based classification are not academic exercises. They define therapeutic strategy, inform surgical planning, and enable the international comparison that will build our evidence base. Third, HS carriers is devastating socioeconomic burden. More than half of patients see their carriers derailed, unemployment is doubled, annual excess healthcare costs reach nearly $7,000 per patient. We must take this case forcefully to health policy makers and payers. And fourth, mental health and stigma are core components of this disease. They require systemic screening, integrated care pathways, and above all, the kind of clinical encounter that replaces shame with dignity. The overarching message is this: HS demands multidisciplinary, a whole patient or total patient approach, and the skin is where we see the disease, but the patient lives far beyond the skin. So thank you very much for your attention.
We are delighted to be joined by another incredible speaker for the first part of this series, Dr. Irene Lara-Corrales, speaking on pediatric hidradenitis suppurativa, including the challenges and opportunities in this population. Dr. Irene Lara-Corrales is a professor of pediatrics at the University of Toronto and a staff physician in pediatric dermatology at the Hospital for Sick Children in Toronto, Canada. She completed her medical training and pediatric residency at the University of Costa Rica in San Jose, and her pediatric dermatology training at the Hospital for Sick Children. She obtained a Master in Science degree from the University of Toronto and is involved in numerous clinical and research endeavors, as well as in teaching commitments. She co-directs the genodermatoses, epidermolysis bullosa, hidradenitis suppurativa, vascular tumors, and cafe au lait screening clinics at Sick Kids, and is part of the multidisciplinary vascular anomalies team. Her research interests include genodermatoses, inflammatory diseases, and vascular anomalies. She is currently the research lead for the Division of Dermatology at Sick Kids. We are delighted to have Dr. Irene Lara-Corrales share her expertise.
Thank you so much. It is a great pleasure for me to be here talking about pediatric hidradenitis suppurativa. We will be addressing early recognition, unique challenges, and global disparities seen in pediatric HS. These are my conflicts of interest. I am not very artsy, and one thing that I do need to disclose is that although I created these slides, I did use AI to improve some of them. So hidradenitis suppurativa is a condition that affects more than just the skin. What I would like to accomplish over the next 30 minutes is to discuss its clinical presentation and the toll this condition has on the physical well-being of our pediatric patients. I will also be addressing its psychological burden that many would call the hidden toll of the disease. And finally, I will wrap up discussing some of the global disparities seen in pediatric HS or the systemic toll of the disease. To start, I would like to start by telling you a story. So we had this experience a few years back that I think it's worthwhile sharing because it was really a learning experience for us, and it was eye-opening. So we conducted this prospective study that was published in Pediatric Dermatology in 2022 to evaluate the association of pediatric obesity with skin problems, with skin dermatosis, and how this affected the dermatology quality of life. At our institution, we have a team that looks after kids with obesity in pediatric age. At the time when the study was conducted, the name of this team was the Sick Kids Team Obesity Management Program, or STUMP Clinic for short. And what we decided to do was that we were going to approach patients when they came to the STUMP Clinic to look at their skin and see what were the prevalent skin problems that they were facing. We were able to enroll 91 consecutive patients. We ended up excluding one of them because he had a normal BMI. So we ended up with a cohort of 90 patients in this clinic. And what we did was that the fellows that were involved with us in this project would be present at the stump clinic and would offer participation in the study to the patients that were seen, offering a full skin exam. And if any skin disease or skin problem was diagnosed, we would be able to offer management and follow-up for the skin problems that were found. We enroll patients between the ages of 6 months and 19 years of age. And what we found was that out of these 90 participants, there was at least one skin condition present on inspection, with a median of 3 skin conditions per patient, ranging between 2 and 5. And one of the things that we found more commonly in up to 10% of our patients was hidradenitis suppurativa. It was interesting that 3 of the patients had been previously diagnosed with HS when they were being seen in this clinic. So 6 were cases that we identified because of the study. And we were surprised by this finding because this was not the primary reason why these patients were coming to the hospital. And we thought it was eye-opening because we are in a tertiary academic center, and many of these patients had been previously seen at our institution, and nobody had made this diagnosis before. We actually found these patients because of the examination that we were offering and because we were looking. Patients were not really volunteering their symptoms. These were not primarily concerns to them, but the families as well, they were not even aware that some of these kids were facing some of these skin changes. So if we think about this, I think that there is a lot that we would need to unpack because of this finding. So one of the things that we need to think about is that in order to make the diagnosis of pediatric HS, we need to know who is at risk and who are the people that we need to approach to screen for the condition. So here are some numbers from the literature. In pediatric cohorts, the mean age of symptom onset is around 11 years of age. The estimated pediatric prevalence is around 0.03%, but we know that pediatric HS is underreported, so this number is likely higher. We also know that in pediatric cohorts, female patients predominate, and this is in keeping with adult literature. And we also know that in up to 40% of pediatric patients with HS, we are likely to find a family history of other family members also presenting HS. HS also exhibits racial and ethnic disparities in prevalence and severity. The highest overall prevalence is observed among African American biracial female adolescents between the ages of 15 and 17. And we know that there is a disproportionate representation in clinical cohorts of both Black and Hispanic youth. This information is important to retain for later discussion during the presentation. So having this in mind, we need to look for HS in some of these patient populations, but in my clinical practice, I am actively looking for HS in different patients. So, for example, when I see patients that have moderate to severe acne, I ask to examine their axillary area and their groin area, because these are patients that are at higher risk of having HS. These patients, again, might not be volunteering and might not be happy that we're going to be examining some of these more sensitive areas if they are coming to see us because of acne. But if we don't pressure to examine their skin, we might be missing this diagnosis. Of course, if I see a patient in my dermatology clinic that is obese, this is a diagnosis that I'm going to have in mind. And in our patient population with Down syndrome, we're also going to be actively checking for HS. In patients with Down syndrome, we know that the prevalence is 7 times higher than in patients that don't have Down syndrome. And we also know that there is an earlier onset of disease in this patient population. So we also need to look for HS in patients with other inflammatory conditions. For example, in patients that have a diagnosis of IBD or inflammatory joint disease, this is something that we should be actively looking for. And if there's a history of pilonidal cysts or pilonidal disease, HS should also be something that we screen for. Knowing that patients with these other inflammatory conditions are more likely to have HS also brings or alludes to part of the networking that we need to be doing with other subspecialties, definitely with GI, rheumatology, surgery, and other specialties. We need to build awareness in them. So they are going to be able to also think of this diagnosis when they are seeing patients that have higher risk of developing it. And we also need to know what pediatric HS looks like in order to diagnose it. Early signs include inflammatory nodules and painful cysts, but in our younger patients, they might start presenting milder early signs like double-headed comedones or inflammatory papules that are clinical markers of HS. In more chronic stages is when we see abscesses and draining tunnels and scarring, but in this kind of more chronic stage, we're less likely to be missing them. We actually want to identify patients early on when we can probably make a bigger difference in their management. The clinical presentation of HS in pediatric patients and the phenotypes of the disease are an area of current interest and the focus of many studies. Overall, it is still felt that the clinical findings of pediatric HS have not been well characterized, and there is still a lot that we need to learn. We had the opportunity to put together a large case series of patients with pediatric HS a few years back. So we collaborated with other institutions, some from the US, Australia, Italy, and Israel. And we were able to put together this 481 patients with pediatric HS. And many of the findings that we had because of this study were quite interesting. So the first symptoms that were reported were found to be different than the clinical findings at presentation or a diagnosis of HS. Unfortunately, by the time that HS is being recognized, up to 50% of patients already have scars, and a significant number also have draining tunnels and ulcers. So what this means to us is that we are not recognizing HS early enough. Also interesting was that the most common symptom reported by patients that they want addressed in their first dermatology assessment is pain, followed by drainage. So up to 65% of our patients are going to require pain management because this is what interferes with their day-to-day life. Pediatric studies have also shown that the distribution of HS lesions is similar to what we see in adults, with axillary areas being the most commonly affected area, followed by the groin, but other areas like the buttocks or inframammary area are areas that are also affected in our pediatric patients. And because of where these areas are, I still would like to find a teenager that is going to be volunteering all this information and openly willing to show us all these more private, intimate parts of their body. This probably also contributes to HS being missed in many patients. Unfortunately, we were not able to determine severity of disease in all 481 patients, but we were able to do so in 288. And what we found was that more than half of the patients are already early stage 2 or 3 by the time of their diagnosis. So this brings us to one of the biggest challenges that we face in pediatric HS, and that is the huge gap between the age of onset of symptoms and the mean age at diagnosis. In our study, we found that there was a 2.5-year gap between these two, but from other reports in the literature, we find that this gap might be even longer. And this is a big obstacle because we also know that the first years of the disease are typically the most severe, and we might be losing the opportunity to prevent irreversible skin damage and psychological distress if we don't improve this diagnostic delay. We might have this window of opportunity that if we recognize early and treat aggressively, we might be able to prevent some of this irreversible skin damage. And we shouldn't be having like a wait and see attitude when we diagnose HS. We really need to be kind of very proactive with its treatment, many times combining multiple treatments in a patient to be able to control it and not let it progress. This is a slide from one of my old presentations about pediatric HS. And probably because what I learned during my fellowship was that we had to have this kind of more stepwise approach to systemic therapies. And this is kind of how I initially presented about the treatment for pediatric HS. But now, after caring for many patients with this disease, I feel I have a completely different approach. The initial treatment sometimes might look more like this, where we are using many different things, hoping that one of the interventions that we suggest are going to make a difference for the patient. So we might need to be using more than one intervention to be able to control the patient. And this probably also alludes to not having the right miracle drugs for HS that would make all the disease well controlled. So from our study, the kind of treatment modalities that were reported were very hard to analyze. But the one thing that was really striking was that the majority of our patients were obese, and many of them suffer from depression and anxiety or psychological, psychosocial problems. But only a minority of them were getting psychological support or nutritional support. So this really is a call for attention to these areas in our pediatric HS patients. And this is even more significant in current times where we are facing a mental health crisis with anxiety and depression reaching very high prevalence rates. The literature also shows that adolescents with HS are doubly vulnerable and that this is something that requires our intervention. When we compare HS to other chronic skin disorders, we see that pediatric patients with HS have dramatically worse quality of life. And pediatric patients with HS also have double the rate of anxiety compared to their healthy peers, and 14% of them develop new onset depression after the diagnosis of HS is made. What is important to realize is that quality of life impairment does not always align with clinical staging. There is impairment even in early stage disease. The physical symptoms of HS lead to functional and social impairment, with patients having lots of difficulties staying odor-free or pain-free, and this doesn't allow them to be able to participate in social activities or school activities that are part of what they should be doing because of the age that they are living. With this huge burden on top, like they isolate themselves, they are embarrassed to participate in activities like gym at school, and this also leads sometimes to missed school days that interferes with their education. And all this comes at an already complex time in their development, those teenage years where there are so many changes happening, contributing even more to the psychosocial crisis, making anxiety and depression even more common. But it doesn't stop there. There is also a big impact at a family level. The burden of pediatric HS carries an emotional and financial weight for the family of the patient, particularly in the early days when a diagnosis might not have been established, leading to multiple visits to doctors or multiple visits to the emergency room. And after a diagnosis is made, there might be a different kind of financial pressure or a different type of emotional weight, with some treatments being costly, and also the family might need to participate or play a role in helping the patients manage their disease. International multi-center studies and the US health system data reveal a harsh reality. Pediatric HS does not impact all demographics equally. We know that the neighborhood socioeconomic status, the patient's race and ethnicity, and the insurance status impact the diagnosis and also impact the treatment journey, creating disparities, and this contributes to further diagnostic delays and greater disease burden. This specific study shows that there is a linear correlation between lower neighborhood wealth and higher odds of having an HS diagnosis. And this data also indicates that there are modifiable environmental factors, for example, structural marginalization, obesity risk, and lack of access to healthy food, that are actively contributing to the onset and diagnosis of the disease. We also know that the race and ethnicity play a role in how a child interacts with their health care system, and this is particularly true for those patients with pediatric HS. Non-white children initiate baseline treatment earlier, and not because they have better access to care, but because they are presenting with more severe disease at presentation, and they rely more on emergency departments for acute care. We also know that once in a system, minority patients face the longest delays from diagnosis to initiation of advanced biologic therapies. For example, in Hispanic pediatric patients, there is a wait that averages more than 24 additional days just to be able to reach the first dermatology visit compared to the general or baseline population. This is also data from the US showing that patients that depend on Medicaid experience a more than 36-day delay to start a biologic for their HS, and those with high vulnerability face staggering more than 207-day delay to start biologics. Marginalized populations also rely more on emergency departments, where what they get is kind of like a little Band-Aid. They go for treatment or symptom management instead of the treatment that modifies their chronic disease. And adding to all this global disparities, the research that is taking place and the research that happens in pediatric HS has definitely been increasing over the last 10 years, but less than 13% of the pediatric HS literature originates outside of North America or Europe. All the foundational epidemiological studies are based entirely on North American and European cohorts, leading to further global disparities on research as well. So right now, we are basing global treatment strategies, guidelines on incomplete, geographically isolated data sets, ignoring variations in genetics, microbiome, and also social determinants of health for different parts of the world. So we realized this kind of years back, and when we were trying to create solutions of how we were going to make this better for our patients, we decided that, we realized that Canadian pediatric patients with HS were underrepresented in global HS literature. So we decided to come together and put this pilot study, creating our pediatric HS registry at our institution. We were able to secure some funding by Skin Canada that funded our project and allowed us to create this registry and pilot it at our institution. We standardized a data collection form, and we created a REDCap based on this data collection form. And we also decided what comprehensive baseline screening we needed to do for all our pediatric HS patients. And this pilot was successfully implemented at SickKids, and we recently published the data of this pilot study. So the preliminary findings are the report on the first 39 patients that were enrolled in the registry. We found that the gender parity is one of the findings that contrasts sharply with the literature. We didn't find the same female global dominance that has been reported. We also found that Asian patients in our cohort were overrepresented. And because we were enrolling patients in our HS clinics, to be able to be seen in the HS clinic, patients have already completed at least 3 months of antibiotics. The disease severity was also very high. Almost 90% of patients already had moderate to severe disease when they came to the clinic, and that is why those are probably overly represented in this initial pilot data. We found that at baseline, almost 50% of patients require immediate involvement from other specialties due to their comorbidities and the findings at that initial visit. The way our clinic works, we have a social worker, we have a wound care nurse, but we have identified specialists within our institution that are willing to see in a more expedited way the patients that we refer from the HS clinic. So we have a rheumatologist, a GI specialist, surgeons, other specialties that if patients come through the HS clinic, we have more easy access to some of those other specialties. We also found that 23% of our patients had Down syndrome, and almost 60% were obese, and about 54% of them had acne and folliculitis. And some of this is also different from what we are seeing reported in other parts of the world. We were also surprised to find that HS was presenting in some atypical sites in quite high numbers. For example, the chest and abdomen. And in patients with a typical site involvement, we found a significantly higher mean body BMI. The percentage of patients with HS lesions, for example, in the buttock area, you can see here, it's almost 70% of patients, is also higher than what has been reported in some previous pediatric HS cohorts. Almost 60% of the patients that we were reporting on were prescribed biologics. Adalimumab was the most common biologic prescribed, and about 81% of patients showed initial clinical improvement. We also saw high rates of primary secondary non-response, requiring increasing in dose of the anti-TNFs or switching to a different class of biologics. And when we diagnosed psoriasis in our patients, we were finding that more than 80% of cases actually had paradoxical reactions to TNF inhibitors. Complete disease remission is very hard to reach in HS, and it was only achieved in 8.7% of our cohort. And finally, we were able to show that the multidisciplinary care that we have been providing in the HS clinic does improve quality of life at the 1-year follow-up. And patients were also reporting less pain at the 1-year mark. Our next steps with this project include rolling out a registry to other centers in Ontario and in Canada. And we also are working on the transition piece between our pediatric institutions to adult centers. So we feel that by scaling standardized registries and providing multidisciplinary care early on, we can alter the trajectory of our Canadian pediatric HS patients. And we have been working hard towards this. So this was just to illustrate a little bit of some local initiatives that we have been working on to be able to improve the care of the patients that we are following. So pediatric HS is too complex to just be followed or have present in just a little dermatology silo. So one thing that we need to do is dismantle a lot of these disparities that I have mentioned and improve the care that we provide our patients in a more unified ecosystem. So we need to really work together with our wound care specialists, with our mental health services, with other specialties, with social work and family support systems to be able to address all the things that are affecting our pediatric patients. More punctually, like we need to transform, make significant changes in the care that we provide for our pediatric HS patients, implementing mandatory quality of life screening and mental health screening from day one, irrespective of disease severity. We also need to improve access to providers with a skill set that are able to recognize disease early on and be able to escalate treatment appropriately. And this can move forward if we don't go down to kind of the disparities in our health system to be able to improve this overall. So we need to continue creating awareness. It is great, all these activities that are happening and will go a long way to create awareness about HS and pediatric HS. We need to recognize those patients early. We need to improve the equitable access, dismantle the compounding disadvantages of poverty and race, and provide multidisciplinary support that restores the adolescent identity and the quality of life in our pediatric HS patients. So thank you so much for your attention. I hope that you were able to take some messages with you and that you keep HS in your minds when you're examining those pediatric patients that are at risk. Thank you so much.
Thank you for joining us and participating in this Hidradenitis Suppurativa awareness webinar series. We want to thank you for your time, and if you enjoyed these series, please scan the QR code to become a GLODERM member, where you can get access to upcoming events, additional webinars, and other programs. Thank you for your time and have a great rest of your day.